Brooks Rehabilitation. I'm here with Kathy Barber, Vice President of Marketing for the Brooks organization. Welcome to Up to the Minute in Clinical Care, which is a regular series that we offer in the College of Health Professions and Sciences at UCF. I'm Barry Hoffman, Associate Dean for Clinical Affairs, and I'm excited. This is a historic first for us today. We are coming to you via holoportation. You are seeing us in a hologram machine, and this is all made possible by the whole Brooks organization. And so we are so appreciative for helping us and partnering with us to elevate healthcare education and transform lives. So I'd like to give Kathy a few minutes to speak on behalf of the Brooks organization.
Thank you, Barry. As she mentioned, I'm Kathy, Brooks Rehabilitation, and I have the day job of working with the marketing and communications team. But I want to welcome you all for participating in this historical event. As Barry mentioned, Brooks Rehabilitation, we are headquartered in Jacksonville, Florida, and we have a great partnership with the University of Central Florida and are really excited to bring together today this holoport technology with UCF. This really is a first. And Brooks Rehabilitation, we are the leader in post-acute care, our entire system of care, and education, innovation, all of those things are core to our fundamentals and what we believe in. So super excited to sponsor this technology and partner with Barry and the UCF team in bringing to you some content, which we hope is the first of many more to come of educational series and to bring cutting edge technology to you. Soon you'll hear from Michael Braun, one of our therapists here at Brooks Rehabilitation, and we hope you enjoy this innovative cutting edge event that's sure to be something everyone will remember for years to come. So thanks for being with us. And again, Brooks welcomes you here, and thank you so much, UCF.
We're so excited about all the things we're going to do together. And before we turn over the program to Dr. Firestein to introduce our fabulous speaker, we have to say that this really, this event came together to celebrate AAC, or Assistive Technology Awareness. So we're very excited about that.
Yeah, it's going to be great.
Hello. Hello. Can you all hear me? Okay, great. It is my great pleasure to introduce Michael Braun. Michael is an occupational therapist at Brooks Rehabilitation in Jacksonville, Florida. He received his board certification in physical rehabilitation from the American Occupational Therapy Association, and he has over a decade of experience in the field. He is a postgraduate of the OT Neurologic Fellowship Program at Brooks and now serves as the program coordinator for that fellowship. Michael has developed the Assistive Technology program at Brooks and currently serves in a specialist role, treating clients both in inpatient and outpatient settings, collaborating with staff across disciplines, and seeking out new and innovative technologies like the one we see today to bring to Brooks. In his spare time, Michael is a volunteer coach of the Brooks Adaptive Sports Power Soccer team since 2012. So without further ado, we are thrilled to have Michael here to present on maximizing AAC potential through multidisciplinary collaboration. Thank you, Michael.
Thank you so much. Thank you so much for the intro, and I'm excited to be here today too, here in Jacksonville, Florida, and then here at UCF in Orlando. I mean, that's kind of weird. I never thought I'd be a hologram, so I'm very excited to be able to help showcase this. And thank you to anyone joining us virtually as well. A lot of different platforms today, and just fitting that we're talking about technology. I mean, it's awesome as clinicians to be able to utilize this technology to network and hopefully learn some things today. But you know, the technology we're talking about today is really for our patients. And you know, the overall goal of today is to just talk about the importance of involving multiple disciplines when we're trying to get the best patient outcomes, specific to assistive technology and specific to AAC today. So I'm happy to be here talking about this. It's a topic that I'm passionate about, assistive technology specifically. Before I was in that role for Brooks, I was an occupational therapist on the spinal cord injury program in the inpatient rehab hospital. about 7 or 8 years. So that's really where I started and really began to be passionate about assistive technology, and really where I started to see just how much you can do for our patients, being able to implement and introduce assistive technology for the different needs of our patients, whether that's for ADLs and activities of daily living, or whether that's through communication. So over time, working with more neuro patients, like Kathy said, primarily in the post-acute setting, inpatient rehab and outpatient rehab, really got a chance to network a lot more with our speech therapy colleagues, our PTs, our OTs, and really come together to show why it's so important to have so many disciplines working together in an interdisciplinary way to come towards the same goal. So that's really what I want to focus on today. It's going to be a different kind of talk without PowerPoint based. I hope to just be able to show you some of the devices and the ways we're doing that. And we'll kind of go ahead and get started. So the next slide here should show just a summary of what's going on for today. We're going to talk about assistive technology and how that relates to AAC, augmentative and alternative communication. We're going to talk about different roles for the different disciplines, OT, PT, speech, but also others as well, like optometry and the physician involvement and how that team approach is so critical. We'll talk about the different devices and access methods. So not only the type of device an individual might be using to augment their communication, but also how they're using it and how that's so important on having a team approach to determine what's going to be best. And then finally, some case examples. So I think, just going through different ways that we've utilized it, and hopefully whether you're a student and haven't gotten a chance to utilize AAC much, or whether you're a seasoned clinician who is using AAC on a daily basis, hopefully you can kind of see some applicability to what you're doing and really just see the importance for our patients of being able to implement that. I think one thing that I've seen with my role as the assistive technology specialist, as an OT, but also with STs who work with assistive technology every day, is like any technology, it's constantly changing and it's constantly being updated, and it's just so important to be able to have clinicians who are able to focus on that and bring that technology to our patients. The other thing is, I think it can sometimes be intimidating to have such complex clients and have technology that's very in-depth and complex. So it's really helpful to have that team approach just to tackle all the changes and all the complexities. Finally, we'll talk about some resources and information for you as clients, or for you as clinicians, but also for your clients. And I think there'll be a panel at the end that can kind of reiterate some of those resources as well. So for the next slide, first off, let's just kind of go through the definitions as a basic, and we'll get that out of the way from the beginning. So assistive technology devices, from my standpoint as an OT, an AOTA standpoint, an assistive technology device is really just any sort of device or product system that can be used to increase the functional capabilities of an individual with disabilities. So that could be something off the shelf, that could be something fabricated or customized, but really anything that will increase the independence of someone with a physical disability. The assistive tech services, which isn't unique to OT, but the services just really takes that process of assessing and evaluating that individual, taking it through the intervention plan, trialing it, being able to access that technology, going over the intervention plan, helping the person obtain the device, and then providing education to the caregiver or the client. So it's really that whole process. And the joke is that that's what separates, at this level, just clinicians who are skilled and have a sense of what the client's needs are from, going to the Geek Squad at Best Buy and, having someone else pick out that technology. So it's really the whole services across the board. Finally, just that AAC piece, which, our speech therapy colleagues just take the lead with, but it's just really that augmentative and alternative communication. So it's in ASHA's definition, it's that specialty practice area where, technology can be used to compensate and really help with speech language production. It could be written, it could be verbal, but just that augmentative and alternative communication piece. So we're going to be talking about all of them and how they kind of mix together today. on the next slide here, there's a lot of ranges of AAC, and as speech therapists, the ones that we see in the hospital, oftentimes there's ways to communicate and get quick yes/no answers with no technology, whether it's looking up or down, blinking, gestures, thumbs up, thumbs down, and then there's low-tech ways of doing things like some of these boards here. So like having a communication board that might have someone point to if they need to use the bathroom, or if they need a suctioning, or a pain scale. So for someone who's not able to communicate verbally, they can point to where they're at on a pain scale or what their needs are. And we'll talk about this in a second, but you can see there's all sorts of different levels of how complex these can be and how many choices someone has to choose from. Or even if someone needs to spell out a communication, there's alphabet boards and a lot of different low-tech ways of doing things. With that, there's a lot of different ways to access these. If someone doesn't have the ability to move their arm or their fingers to point to the selection, there's different ways of doing that. On the screen there, you might be able to see there's a stylus. So something like this. This is from iFaraday. So Faraday Styluses is the website, and we as clinicians can, if someone has gross movement but not so much fine movement, but they need to access a communication board or even a phone or a tablet, something with text to speech. These are ways that we can help someone directly select an option. These are flexible styluses, and we use these quite a bit in the hospital. Again, even if someone doesn't have finger control, either with a wrist support or just kind of molding it to their hand. These styluses have special tips, which are kind of rounded and really just at any angle. They can either point to the selection or do things on a tablet screen or a phone. Another way of doing that would be to make a selection for using a laser. So there's a picture on a screen there of different lasers that are sold that can clip on either a headband or a hat if someone had head control but weren't able to do the speech production, or if they had minimal hand control, they could point to different options and make selections kind of with that laser pointer technique as well. So those are different low-tech options. The things that we'll talk about today from an inpatient post-acute side of things would be more of the high-tech options. So the things on that side of the screen, more the speech generation or the speech generating devices. So I don't have any affiliation with any of the companies. The things we talk about today are mostly just things that we've utilized in the hospital and have different familiarity with from our clients. But so a speech generating device there, the one pictured there is a Tobii Dynavox eye gaze system. So that would be a more complex device, and there's different ways to access that. So those are the things that we'll be talking about today, from low-tech devices to all the way to high-tech devices. So let's go to the next slide here. So in my role with Assistive Technology, there's a lot of different areas as an OT that are common goals for individuals as soon as they might, after an injury or an illness, there's different, goals right off the bat that people have. Communication is so important to be able to communicate with staff, whether that's a call button or whether that's being able to communicate with the team, communicate with family at home. These are some of the other goals. There's 5 bullet points there from an OT side of things that I find often are top goals for people, but you'll see as we talk about them that they all intermix and pertain with this AAC aspect. And that's why I wanted to spend just a little bit of time just highlighting these, because it's going to be important, I think, when we talk about the AAC and how we can all collaborate, that the AAC devices, especially the speech generating devices and the modern devices, they can have a lot of other functions besides speech and language production. There's a lot of ways to incorporate activities of daily living, leisure, social interaction, all these different types of goals that OTs and other disciplines can take a lead with. So the first one on there is just device access, so phones, tablets, computers. As speech therapists know, these can be valuable tools for AAC devices with either text-to-speech options or having people write things down, whether that's someone with aphasia or someone with just voicing difficulties. If there's normal motor function, this can be a quick and easy way to do things. Even on that other slide, there was something called like a boogie board, or just like the marker boards that people can quick write things down. In this case, using phones, tablets, computers, especially for any of us, if we're kind of tied to our devices at our hip, and then have all of a sudden a traumatic accident happen, not being able to be connected and not being able to communicate with family, friends, loved ones, especially with COVID times where a lot of times visitors can't come in or come travel to the inpatient setting. That's a huge goal and a huge reason that we want to provide ways to communicate and interact. So even from a written language and a social interaction perspective, this is so key, and we'll talk about some of the ways to access these things going forward here. The next one is that home environment, so that ECU. So when we say ECU from like an OT side of things, that's really environmental control units or ways to control the environment. And we'll see, talking about some of the AAC devices, how that's a real option now for either connecting with Bluetooth or connecting from like an IR or a remote control standpoint. A lot of the devices nowadays, even power wheelchairs, will connect to our devices. And if you can connect to a phone or a tablet, then a lot of times, just like any smart technology, you can connect to your environment in your home, whether that's for lights or whether that's for bed control, a whole sort of thing. So it gets into a lot of other ways of communicating and leisure aspects. Return to work and return to school, communication is so vital to that. So as OTs and PTs, we make recommendations for environment, for positioning, for seating, for other adaptations in that space. But whatever AAC device and whatever access method is going to be chosen to utilize for a daily basis for communication, making sure that's compatible and the return to school, if those are goals, are mixed into that consideration. ADLs is the last one that we were just talking about, and really just that echoes the OT standpoint of things: the leisure, the social communication, whether that's Instagram, Facebook, getting on social media. Those are ways of communicating, and a lot of times individuals might need adaptations if they're not able to just make a phone call and dial up their friends or have access to those devices. Even in the hospital, we see individuals who don't have their speech for whatever reason, post-stroke, post-SCI, if they're have a trach or they're on an event, they still want to be able to FaceTime and see family and friends. So providing opportunities in a collaborative way to access that side of communication is important. Okay, so let's go to the next slide here. So these are some of the access methods that I think, as we start to talk about the other disciplines and how it's important, we'll get to some of the specific examples for access methods in a second. But like we talked about with some of those communication boards, for our clients, again, in post-acute care, a lot of times the clients that we see at Brooks are neurologic injuries. So after a sudden injury or illness or accident, not as many developmental considerations, but there are some of those as well. So these individuals have to find a way to access their communication device, but there's a lot of different considerations. So there's motor considerations. A lot of times our clients don't have full hand control or arm control. There's cognitive considerations. This is an area that we know spans PT, OT, ST disciplines. If someone's not able to attend to the questions or attend to be able to read all the choices on the board, that's going to make a big difference. And the same thing with vision. We all know after neurologic injuries, vision can be affected. After a stroke, that could be neglect, it could be a field cut. There's all sorts of things. At Brooks, any patient who comes in with a neurologic injury is screened by an OT for a low vision exam. And so those things that we would look at would be acuity, so after an injury or a head injury, after a surgery, vision can change. So as STs, OTs, PTs, if we're asking them to look at, a set of instructions or read a communication board. If their acuity has changed, but they can't let us know, that's going to be a big issue. So acuity, scanning, being able to scan left and right, up and down. If someone's going to use eye gaze as an option to access, are there difficulties with scanning left and right? Do they have double vision? Is there going to be a need to maybe occlude one of the eyes so that the double vision goes away and they can attend and really read the choices of what they're talking about? Those are a lot of the things that the OTs might look for in a vision screen. And similarly, optometry is a large part of the plan of care and the assessment for patients who have neurologic injuries. So the optometrist is able to provide, orders or recommendations, and really if someone needs like a prism or an occlusion adaptations, the OT is really the primary discipline that the optometrist is able to, at least in Florida, able to get orders to and really influence that plan of care. And there's other interventions as well that we'll talk about that the PTs have a direct involvement in. So that piece with vision spans optometry, neurooptometry, OTs, and speech therapist PTs as well. It's so important. The seating and positioning is also a large aspect. So if someone is using a device in the bed, but their seating in bed is much different than in a chair, we see this a lot with feeding as OTs. So someone might be able to feed themselves rather well when they're sitting upright in a chair, but in bed, if they're reclined, if they're in a different position, and they have a harder time moving their arms or a harder time seeing a device or a communication board, the positioning and seating considerations can be so different than someone's positioning in a bed versus in a wheelchair. But as we all know, the communication needs don't just disappear because we're going back to bed for the end of the day outside of therapy. So we really need to be flexible and have ways to incorporate that throughout multiple disciplines and in all different times of day. That way nursing can be on board, clients can talk to physicians. So we really need to talk about how different, especially if we're using these high-tech devices, how these devices are going to be mounted in the room, at the bedside, in the wheelchair, or on the wheelchair, so wherever they may go, that those needs are taken care of in a consistent way. So let's go on to the next slide and talk a little bit more about access methods. So you probably should see about 6 pictures here of some, representing some different access methods. And we'll kind of go through and talk about, the common ways, each one of these, but relating to those motor, cognitive, and vision concerns and how someone might interact with a device. So I think right off the bat, the first thing that I'd want to just showcase is that there's different ways of interacting with a device. So if you have a speech communication device, we talked about that direct selection. So it's similar to if I wanted to do something on my phone. If I wanted to open the Photos app on my phone, I would just directly select Photos and it would pop up. If I was going to use a eye gaze system or use vision to access something on a screen, then I would look at that Photos app either on my computer or on the speech generating device. Wherever I look, if I sustain that gaze, it's going to dwell, and if I stay on that symbol for half a second, 1 second, 2 seconds, depending on what we as therapists set up, then it's going to access that and select that directly. So those are 2 ways of direct selection. The other way is more scanning, so having a large box of choices and then activating some sort of switch to select what you need to hit. So and gradually making less and less choices. So in the case of a phone, I might have all my apps selected, and I would have to select which column I wanted, and then which column I wanted, and then which row. And so I might have to select it 3 or 4 different times. So if your patient is going to utilize switch scanning with either a single switch or a double switch, there may be extra time involved, or it may. Let's show you here. So this is a very simple type of system with just yes, no commands. But we have direct selection where if you
Yes.
pressed yes, it would select yes. We could utilize eye gaze, where if the individual was looking at yes, they could focus their gaze on yes for a full second and
Yes.
access yes. Or we can have a system where switch scanning goes back and forth. So you may be able to see on the screen there's a blue highlight that switches back and forth. And if we plug in a switch, we can time it
No.
to where we want the selection to be. So this is only a choice of a field of 2 options, but we can make as many as we want, all the way up to a full alphabet. So someone with a single switch could just press this
No.
to activate it and make individual choices. It might take 3 or 4 clicks or take a longer time. Or someone could use 2 switches, one for scanning and one for selecting. The final way to do it would be to use a combination of the 2. So you could select something directly with eye gaze and then use a switch to select it if someone had a harder time focusing really in on that individual subject. So there's a lot of different ways to do it. And then as therapists, as OTs, PTs, and speech therapists, we can kind of figure out what's going to be the best way to do things. And I think there's so many considerations with that. How long are they able to attend to the choice if the choice is scanning? Are they able to see what's written from an acuity standpoint? If we need the box size to be this big, then there might only be 3 different choices that we can fit on a screen. If they are not able to be accurate with direct selection, we might need the choices to be much bigger. Same thing with vision and scanning. A lot of times we may need to start with 2 or 3 boxes for a field of 2 or 3, and then narrow it down from there once acuity gets better. And those are things that we can practice in therapy from an OT, PT, and speech therapy standpoint as well. So this is, talking about eye gaze and vision, this is it's called a PCI Plus. So this is a form of an eye gaze scanner. This has a USB port on it, and this can be utilized with Windows control. So on a Windows computer, someone could have complete control of, we talked about getting back to work, a Windows computer, but this is the same type of system that is on that device that I just showed you there. So again, a lot of companies have, Saltillo, Neuronode, Toby, a lot of these speech generating devices have this eye gaze capability, as well as one that we'll show you later from ASI, which is specific to either home units or environmental control units in the hospital. So this is kind of what that eye gaze scanner looks like. So let's talk about a patient example with that. So we had a patient come into our SCI floor, and she was a young lady who had a high level of cervical injury. She was in a halo. She had good vision and good cognition, but very little motor movement. She had poor speech control. She had vocal cord paralysis, and because of some of the deficits in her tongue and her respiration, she wasn't able to have intelligible, no vocalizations, and really lip reading wasn't a good option for speech, at least at that time going forward. The speech therapist was able to implement a speech generating device with eye gaze, but through the OT and PT collaboration, they were able to see that the individual actually had very small movement in their right thumb, as well as small movement in their left big toe. And so this opened up another avenue for them to be able to utilize switch control to be able to scan and select 3 different items in their plan of care. They are able to quickly be able to put together sentences, again, because they have that high cognitive level. They were able to learn pretty quickly to be able to communicate with the physician, the speech therapy team, make their goals known, and answer questions more quickly, other than just some of the basic yes, no's, and some of those basic needs. I think the other thing to point out is that that person was able to identify as doing that repetitively, but they fatigued pretty quickly. So these were goals for OT and PT to really focus on, because that was so vital and important to the communication for that individual. But again, the seating and positioning was different from in the bed versus in the chair. So they were able to utilize something called like a foot switch here. So we were able to kind of mount a foot pedal switch that was plugged into the device, so she could utilize her foot to make selections and her thumb to do the scanning. But the scanning for the thumb was very, very small. It was something that was Velcroed on and just, you know, designed so that they could do multiple repetitions without getting tired, but the positioning of her thumb had to be in the exact right position, you know, kind of in a gravity decreased plane. So these were all ways that we talked and communicated among the team to make sure that nursing, PT, OT, speech not only was setting them up in a way that was successful, but also working and including those goals in the intervention plan going forward. Another individual in the inpatient hospital, this was someone who had a stroke and essentially kind of had a presentation of locked-in syndrome. They didn't have any motor movement in upper or lower extremities, and head control for switch options wasn't an option. They also had a difficult time with scanning, so the neurooptometrist, because of double vision and an exotropic, one of their eyes was deviated to the side, so the OT was able to occlude their vision and really focus on making the vision a little bit more clearly, but because of their injury, they were really only able to gaze in a vertical pattern and not gaze horizontally. So this really decreased the amount of options that with the speech generating device they were able to get. Through collaboration with the OT, the speech therapist, and the vendor, you know, this team set up a very narrow window where the patient had to focus on just the choices in the center, and they were able to focus on 2 or 3 choices initially. It was very hard to sometimes get feedback from the eye, just the way it was positioned. So, you know, the OT and the PT collaborating, that speech generating, or the actual eye gaze device needed to be a little bit higher to keep that person's eyes looking up. And, you know, you can imagine that if the device is down here, it just kind of gives the appearance of the eye being closed. So, you know, having the position of that device always a little bit higher, and then coordinating with the physician. This patient was very drowsy, so just doing, you know, kind of trying to realize what times in the day were going to be best to make the most gains and get the most communication. This patient was able to work with their OT and ST to get to a field of 9. They were able to train the caregiver to utilize the device in the room, and eventually they were able to get to the point where this patient was able to use some of the keyboard functions, which I know speech therapists will know is sometimes the hardest part, and changing between different screens, but he was able to give like a PIN code for banking to his wife, and they were able to access some of the accounts she needed access to, which was very helpful and something that, you know, she had been trying to get from him and didn't have access to for a long time. So, you know, again, the access method, also the intervention plan, and the seating positioning considerations, I think were important things to highlight. He actually wound up coming back to the inpatient side, and we were able to utilize some EMG type trials for switches. He wound up getting a little bit of return in his left arm, and that's something that on the screen there you'll see at the bottom right. You know, I have NeuroNode on there as one of the examples. There's a lot of different types of switches. So NeuroNode is a more wireless switch, but using EMG potential. So just muscle activity, even if someone doesn't have against gravity ability to constantly access a switch, you know, hooking them up to, you know, sensors, electrodes, just basically trying to get that muscle activity, that muscle signal to be able to access that switch can give people a whole nother avenue of how to control that speech generating device, especially in this case where eye gaze was definitely a limitation and a barrier. So I think between the direct selection, we showed the stylus on there, we showed the EMG switch, we talked about vision, we talked about direct selection with touch, and then switch control. Those are a lot of different avenues. There are some other ways to access, you know, systems like tablets, computers, and phones. I wonder if I actually disappear when I do that, and then just kind of poof reappear, and it'd be interesting to see how that looks. So this is one of the like the Bluetooth mouses. It's a wearable device. There's others with headbands, or even now they have earpieces where it just is kind of a gyroscope where, depending on if the client looks up, down, left, or right, that is the cursor on the screen to be able to make selections. These have a port that can be attached to a switch. So this is the cursor, and then either, you know, a hand switch or a bite switch or something like that is the mode for selecting. So again, on computers, phones, tablets that could be used for communication, that could be used for social interaction, that could be used for typing an email or messages on Facebook. And we've seen that with some of our clients, just being able to very quickly go on a screen and make selections. Samsung even has an app for no equipment needed. You can download the app and it will read your face, and depending on if you look up, down, left, or right, just by the facial features in the screen, it will have a cursor on the phone, and you can dwell and have complete use of your phone just by your facial motions and features. So that's another access method as well. Let's go forward to some of these other considerations as well here too. So from a mounting and seating and positioning standpoint, some of the things we talked about were concerns can be different from the bed or from the wheelchair. The positioning of the client and the positioning of the devices can really play an important role. Like that gentleman, whether it was too high or too low, that can be the difference from it being able to pick up his eye and being able to communicate. And a lot of times at night, or if there's nursing staff that isn't familiar with the device, they may not know. So really finding what works and then communicating with staff can be so important. I think some of the mounting systems are also key though, so I can showcase some of those as well. We've had individuals here who have been, for example, in a have come 3-4 months after an injury, and they get here and maybe their neck, because of tone and other musculature, is in a fixed position, and in the bed trying to position a device in that setting, and depending on which side of the bed or up in a wheelchair, just trying to get their head into a neutral position can be so hard. Those were cases where we really had to work with PT to try to work on stretching, positioning, even the physician with considerations for Botox, etc. Those were really tough setups initially before we were able to even utilize the AC. The positioning was kind of a main barrier. Similarly, for people who have AAC needs but maybe have good motor control but are in a power wheelchair, just having access to the device can be so important, especially if they're not using and are used to using an AAC device. There are a lot of different considerations and customizations for mounts for a wheelchair. We have basic things for things like mounts for a phone. This is a kind of a modular hose, very basic type phone holder. So if someone was using a phone for text-to-speech, this is something that can clamp onto a table or onto a wheelchair and can very easily screw in a phone to have a phone in a set position in their wheelchair, whether to tilt back or tilt forward or on a bed rail, and keep that device in a constant position. Same thing for a tablet. Tablets can be a little bit heavier and also have a lot of speech generating apps or communication boards on them. This is another more metal type version. This is not going to move, whereas that modular hose option is very moldable and can move depending on where the patient needs it or needs to transfer in and out. This is one that has either an option to mount onto a bed, or it has an option to very quickly click and disconnect, so that the mount would always, or the device or the tablet would always stay in the same place, just mount it on the wheelchair, click it on, click it off, and whatever the mounting hardware is stays on the wheelchair, always in the same place. And it's very easy for caregivers, nurses, staff to take it on, take it off. And it really just makes it more easy to utilize. That's the one thing about assistive technology in general, is that, such a high percentage of devices go underutilized as soon as someone gets home, and may get put in the closet, or just it's the preference for the individual to keep it over on the table in the corner. But if we can really streamline that process from a mounting, positioning standpoint, make it accessible to them, the percentage chance that they're going to be utilizing it on a consistent basis with staff and therapy in the home just really goes up. What we try to do here from our outpatient perspective is we really try to have the OT involved with any AAC evals from an outpatient ST perspective, those are, you know, in the process of trying to get funding, you know, that is really driven by the speech therapist and you know, going through insurance and showing the need for that speech generating device, for that AAC device. But you know, having the collaboration of the OT to talk about positioning needs, mounting needs, being able to take measurements and you know, collaborate on that assessment to know what's needed right off the bat and contribute to that report is something that we found very valuable in our setting. The mount that we were using before, this is a very easily adjusted floor mount. It can take, you know, depending on what the size of, or depending on the weight of your tablet, you can adjust it so that no matter what.
Yes.
It agrees with me, but no matter what position you have it in and what angle, it can very easily be rolled up underneath the bed, rolled up onto a wheelchair, and it's very easily adjustable and also taken back by nursing staff if they need to quickly access the patient. But that's not always, you know, going to be the best option for someone from a wheelchair level, you know, in the home and being portable. So discussing with your client what their needs are and whether that's an option for at home and what other, you know, sometimes clients may not know or get that power wheelchair or get that manual wheelchair, their custom wheelchair for quite a few months in that outpatient setting. So even coming back and having that collaboration with an OT or an ST at that point to really go over the problem solving with the mounting in the home setup situations can be very important. Another, you know, I think another thing is important that we talked about before was just from an intervention planning standpoint. So one of the CVA patients we had in our inpatient facility had just a very tough time with AAC. There was some very minimal communication that could happen between the client and her husband with gestures or with mouth gestures, but she didn't have the ability to, you know, formulate words or mouth different speech. It was mainly with eyes, so looking up or down, but even that was not consistent with him and with the other staff. It was a challenge to get simple yes/no questions. She had difficulty with her eyes gazing side to side and difficulty sustaining that vertical eye gaze as well. So one of the things we were able to do is collaborate as a team on what we thought might be viable access options for a speech generating device. So with an option for eye gaze, we were able to take some of the intervention recommendations from the optometrist, try to tap into some of the reflexes dealing with the eyes to look left and right, and the OT and PT were able to do some really innovative treatment sessions in standing frames in really working on trying to have her sustain her neck posture, have her be able to look side to side even as much as she can and build on that over the course of days and weeks. And then using what's called like VOR type of exercises, really trying to expand the amount of horizontal gaze she could have. This is someone who had a lot of barriers with access, but she was able to eventually utilize a different way because the eye gaze was so difficult. This was a client that was able to use, again, one of those modular hose mounts that we talked about. This is something that has just a simple, what's called a pillow switch at the end of it, and it's just Velcroed on. But this is something that was very easily connected with this clamp here, either to the bedside or to the wheelchair, and just put kind of laterally to the side of her head. So I think in the next slide, there might be kind of an example of that with the wheelchairs and the different mounts for modular hose. Again, this is one that we typically utilize a lot, but there's a lot of other types of Assisties with you know, DASI mounts or RAM mounts, things like that. So there's a lot of different kinds you can use, but this is something where she had a switch on her the side of her head that she was able to activate to scan and select, and one on the other side. It was actually the top of her head. She could look up and she could look to the side, but not to the other way. So there was a lot of problem solving, getting the positioning right. Again, where she was positioned in the bed had a had a factor with that where she was positioned in the chair, but it was something that was able to be built off of with her husband and in going forward. I think that case also, for the people who might deal on a little bit more regular basis with AAC, just kind of highlights the fact that a lot of this problem solving, if there's resources, if there's ways to access this in a hospital in an inpatient setting, there's not always a promise of having this equipment available when patients return to outpatient settings or rural settings. So this patient didn't have, the therapist that they went to didn't have a lot of experience from a speech therapy and an OT standpoint with AAC, and it was a little bit of collaboration between the clinicians that saw them in the inpatient side, trying to just get the other clinicians up to speed, trying to locate vendors in the area that might be able to provide assistance or other resources in the area to continue to use that equipment, continue to train on it, have it be part of the intervention plan going forward. But I thought the PTs and the OTs did a great job in that case, just really collaborating with the speech therapist with a intervention standpoint, and her head control and her neck control did improve. It was just one of those cases where it was still a work in process, just given the complexity and the severity of the injury. So let's go to this. Let's go to this slide here with the leisure and ADL. So this is an area that a lot of our outpatient collaboration happens in, especially for clients who may already have an AAC device, but just because they've already received their custom AAC device doesn't mean that it's kind of everything's good and they're proficient with it and they're using the device to its full capability. So this is one area where as an OT specializing in assistive technology, I often get referrals from our speech therapy counterparts for specific goals related to social interaction, related to environmental control and access methods. If the access method isn't going exactly how they want, or if there's other opportunities to blend those access methods, like we were talking about, sometimes vision with switch control or direct selection, especially as people might get more motor gains. So there's a couple different examples here. One is an individual who'd been using a eye gaze device mounted on their manual wheelchair for quite some time, but they had goals to be able to utilize the TV in their home. The individual's mother was, having to do a lot of work with shutting off the TV, changing channels, especially late at night, like the client liked to stay up, and the mother would sleep in a different room. And then when the client wanted to go to bed, the TV would, stay on and the volume would be up, and they were looking for other ways to connect in their environment. Now, there might be ways to do that with a phone or a tablet, but being able to utilize his AAC device to do that was very important, so there weren't multiple systems involved. So, as an OT plan of care, we were able to work with the vendor or the manufacturer to, what's called unlock the device. So open it up, gain access to the internet. When devices are obtained through insurance, typically it's for speech generation or speech generating purposes and direct communication, but there's not always access to the other features of what you can think of as the computer and the other capabilities for the tablet. So this person was able to pay just a small fee. I think it was like $20 or $25, and was able to open up the tablet, and then together we were able to program the device. There was there's a receiver on the back that you just basically point your remote to. So his remote at home brought it in, we pointed it in, we made 3 favorite channels. I think it was ESPN, ESPN2, and Comedy Central. So it was like his 3 choices, but he could do power, he could do his channels, and then he could mute the TV on and off. So it really was a big independence goal for him, but also it was a huge help to the caregiver just to, with that specific struggle that they were working with that night. And that was, one of these areas of, leisure ADLs and ECU considerations. There's another individual that came in pretty far post brain injury, and he again had a speech generating device that he was working with. This was a Saltillo device, and he primarily used direct selection. So he He took some extra time to make the selections with his finger, but he had some specific touch accommodations on his tablet. So he might move his hand while touching the device, but then where he let up last would be kind of what was selected on the screen. And he was able to use different page sets and type short messages with extra time. But he wanted to be able to communicate with his friends, reach out on social media, make text messages, and he had a very hard time. So I got the referral from the speech therapist from an OT side of things, and we were able to trial things like a phone, a regular phone and a tablet, which he was able to reach, but it wasn't an ideal setup. Then he had two different devices mounted in front of him, and the positioning was different for each, and some of the sensitivity settings on the screen wouldn't allow him to do what he needed to do, and the size of the device was different from a vision perspective. So what was important in this case is, again, opening that device, but being able to work with the manufacturer and the vendor, which is so important. I'll kind of talk about that as one of my final points, but again, going through the process of opening up the device, downloading an app on his tablet and downloading an app on his phone to be able to get all his contacts immediately synced to his device. So with a Samsung phone, he was able to access the full capability of texting from his same AAC device. So immediately he was able to text mom messages that went right to her phone. So she didn't have to be right in front of him to be able to communicate back and forth with him with messages. So either down the hall, across the room, or texting other family or friends at their home immediately became open to him. And that was something that he wasn't able to do before unless he was typing it out to mom, having it generate speech, and then she was putting it in his phone. So just eliminating that one step was a huge growth of independence for him. Another example with that individual client is with unlocking the device, we were able to not only identify different leisure games and apps that he could utilize on the screen, things that he enjoyed doing before with puzzles and different games, but also having access to Netflix, having access to Instagram, which when he found that out, that immediately kind of trumped the texting. That was his number one goal. And then also Facebook. So this was an individual who had Facebook happy birthday messages in there from like 15 months ago that he had never been able to reply to, especially on his own, but he had the capability with extra time, but independently without mom's help to be able to go in and have access to message or again, get on Instagram and like and scroll to different things. So that was an area of, again, social interaction, written form of communication. He's someone that had also kind of mastered the, what's kind of called like a mid-text solution to be able to use his speech generation device to make other commands. So, how many people have an Alexa at home, or how many people use Siri for this and that. When Alexa is connected to things at home, my favorite is connecting it to the Christmas tree lights. So my kids can turn on and off the Christmas tree lights just through Alexa. But there's a lot of different functional applications to that. So turning on and off a light when it's time for bed, or checking a sports score, any number of things, playing music, right? So that's a big thing, just having Alexa play music. So this individual is able to have preset, working with the speech therapist to have preset buttons to generate a familiar phrase, hey Alexa, play music by whoever it is. So he was able to take advantage of that, the speech generating capabilities of his device to then interact with some of the other things like Alexa, like Siri, things like that. And I thought that was pretty cool. The last thing I'll talk about here is with an individual that came in and similarly had vision deficits, had motor deficits, had speech production deficits, but was able to gross motor, hit different buttons and switches. We were able to set him up with a lap tray, and he had one as well, but that's something that we often utilize with clients, especially newly to a wheelchair, just to have a setup where they can have different switches or speech communication devices. And we were able to use different recordable buttons to make kind of preset recordings for what he wanted to say. So I have no clue which one's which, but we were able to do things like this. So like, hey Siri, what's the weather today? His big thing was like, hey Siri, call. Apparently there's a lot of weather today because my Siri is still reciting the weather. It's 73 in Jacksonville today, by the way, in case you're there. I don't know what it is in Orlando, but or like play music. So
Alexa, play songs by Taylor Swift.
So I'll just assume Taylor Swift is what he wanted to play, and this wasn't what I wanted to play. But you get the idea of using either the speech generating device or other recordable buttons like that to make specific commands, just like you and I might use our voice assistants for each and every day. The final piece of technology just I wanted to show as we're kind of nearing up to the end is just something like this, which is a screen we're able to bring in and out of the room, and it has different page sets on there, and we're able to bring this kind of over the bed and talk about pain, have different communication settings. We're able to control the bed up and down, the call light, nurse call, the TV functions. It's kind of a global ECU, but it has capabilities for eye gaze. It has capabilities for using a sip and puff straw as a switch control, or other switches as well to scan and select. Some clients use it with a microphone, but again, a lot of different access methods, a lot of different ways to utilize things in the home, and also for our clients just newly to our environment. So let's see. So let's go to the next slide here. Final things as I'm wrapping up here. So these are just some of the considerations that I like to focus on, when I'm talking about AAC, and just kind of some things to leave you with. A lot of times this is it's a collaborative approach between the client and the clinician for developing what their goals are for assistive technology, and same thing for AAC for sure. This is such an important goal, and what they may have to or need to utilize for quite some time. So really trying to fit their goals, matching the features of what they can do, but also what they want to be able to use it with. Sometimes it's difficult to have conversations with implementing new ways of doing things. So, I just wanted to leave you with a couple of things here in terms of like the way that we frame conversations. Sometimes it's changing roles, the way someone might do a task or the way someone might communicate, or it could just be, someone might not be willing to accept a new way of doing something, a new way of accessing something, but it can be something that we just present as like, I know we're still working on those goals, and we want to be able to get there, but in the meantime, these are really ways that we can get you an increased level of independence and access to different devices, communication, etc. I think technology challenge is such a big, important thing. That's something that's talked about in this Cook and Pulled, our book, which is a kind of a classic assistive technology book. It's, if someone was able to program their VCR in the past, that's a pretty good indication that they're, have a high technology tolerance. If they, if their spouse says that they were using a flip phone still, or very rarely, that's an indication that bringing in a very big complex piece of equipment and technology to try to communicate may not be your best bet initially. It may be something that you would have to work up towards, or starting more simpler is definitely a consideration there. And then money considerations. So I think we just have a couple more slides, but that money consideration piece is so important. We'll kind of talk about that resource and grant piece at the end here. We're on a slide here that shows the ATP certification in RESNA. So that ATP certification is something that's sponsored by RESNA, who does a lot of advocating for the use of technology for individuals with disabilities, but it's an association that also gives that certification to clinicians, to vendors, really as an assistive technology professional. So it's something that, typically it's 1,000 hours in the last 6 years. It depends on kind of what your degree is, but for clinicians with, a master's degree, it's right around that 1,000 hours in the past 6 years, and it's a test that you would sit for, and it's a 200 question test. It takes about 4 hours, and then that's a certification that if it's something that you're interested in being specialized in assistive technology, that's definitely something valuable that just certifies to the community that you're specialized there. A lot of PTs and OTs may have a seating and positioning specialty that's certified by ResNet as well. So there's a lot of different options there. In the next slide, this is just really my final point, is it's a constantly changing landscape. So networking, having clinicians, having conferences or education events like this where you can make connections and have someone to collaborate with. My contact info will be at the end if you ever want to reach out or have questions. But that was something incredibly valuable to me at the beginning when I was developing my skill set with assistive technology. Going to ATIA, which is in Orlando, in January on a yearly basis, going to AOTA conference, or likewise APTA, ASHA, things like that have vendors, demos, clinicians giving talks. There are listservs that are listed there on the web or on the PowerPoint where you can ask questions to other clinicians or search back in the history and see, if you're not able to do things. But oftentimes, let's go to the next and final slide here. You can look at websites and resources. There's different hospital websites that are just really strong resources, Pinterest sites, things like that have access. I'm sorry, one more slide. Sorry about that. But the vendor relationship is also really important. So that's that last point there. Just being able to communicate with manufacturers, vendors, other clinicians, other disciplines is just so important to that whole picture. So that's my final thought. I think we're going to talk about FAST here in a second, and I just want to kind of give an intro there to that Florida program. That it's something that at Brooks we take advantage of. We have a distribution center in a location just 3 minutes down the road. We're very lucky. There's locations all across the state, and I think I'll let our colleagues from UCF elaborate that on a little bit more. But I want to say that is something we utilize for loaning and checking out devices for the clients. So thank you guys. The last slide on there has my contact information if you have any questions. But it was fun to be able to be a hologram and be able to talk about some different equipment and show equipment. And so I'm gonna hand it off to I'm gonna hand it off to Julie from UCF to kind of take the next few minutes here to provide more information, and then I'll be back for questions.
Well, thank you, Michael. This is Jennifer Kent-Walsh coming to you from here on the panel with you from UCF. And I have the pleasure of serving as the director of our Assistive Technology Center that is funded by FAST here at UCF, as well as the Associate Dean for Research. So I'm going to ask you to go ahead to the next slide. But just as before I get into providing a little bit of overview and resources that we can offer here in terms of AAC related research, I wanted to thank Michael again and just really give you a little bit of background as we were developing this panel and thinking about all of the ways that we would be celebrating AAC Awareness Month here at UCF and following up on an assistive technology fair that we had last week. And we're so fortunate to have many faculty, both academic and clinical, conducting research, delivering services, providing community support for individuals who have AAC needs. Have those in speech language pathology as well as in physical therapy, and who hold the designation, as Michael was mentioning, as ATPs, as well as certified clinicians. We really wanted to branch out in our panel and include an occupational therapist and get that perspective. We know that AAC services are best delivered in a collaborative manner, and Michael did such an amazing job of looking at all of those different aspects of what we need to learn from and how we need to partner with those personnel in other areas to be able to provide the best possible services for our clients with complex communication needs, whether it be inpatient, outpatient, educational settings, whatever clinical setting. There are so many considerations. So we really appreciate those case examples that he was able to provide. Of course, the collaboration theme continues when we're thinking about developing new technologies. We're using this holographic technology here today from an educational standpoint, but there are, of course, all kinds of applications that we are excited about looking at moving forward in terms of providing AAC and other assistive technology related interventions. And that's really best done in the collaborative team manner. So one resource that we wanted to highlight both for our local community and those who are joining us through Zoom is also the research opportunities that we have. And these are referrals that you can make to families, to clients that you're working with who may be able to participate in our research studies. And both in AAC and other assistive technology areas, but also in other educational and rehabilitation intervention studies, development of technology studies, et cetera. So we have a fabulous website, which is highlighted on this slide, that is our college, so the College of Health Professions and Sciences at ucf.edu, and you see that the extension there, research and studies. And if you go onto that website, you're able to search to find what studies we have currently going on that are enrolling participants. And when you click on the information for any individual study, and the one that happens to be up there now, as you see, is focused on AAC, you get some additional information as to whether or not participants are paid to be involved in the study, what the time period is, what the qualifications to participate, et cetera. So we want to highlight that for you, not just for this particular study, but to keep that as a tagged reference for yourselves in the future as you move forward, to be able to refer your clients to participate with us in research. So from there, I'm going to turn things over to Poonam to talk a little bit about FAST, as Michael was mentioning.
Thank you. So as was mentioned, the Florida Alliance for Assistive Services and Technology, or FAST, is a service, a free service to Floridians. And what it does is really it helps us to provide access to assistive technology and AAC to everyone. So that includes clinicians, clients, caregivers that are supporting, and everybody here. So we hope that you guys take advantage of that, and the fact that you have a FAST Center right here housed at the UCF Communication Disorders Clinic along with the AAC Collaborative. So that's pretty exciting. And the services that can be provided through FAST include education, referral services, loans and publications, trainings and demonstrations. So the mission really is to improve the lives of Floridians by providing this access and increasing awareness. So, but what better month to let you guys know about that than AAC Awareness Month, right? We here at the Florida, the FAST Atlantic Region Demonstration Center right across the way in Suite 250, we serve 4 counties: Orange, Volusia, Seminole, and Brevard. But all of the centers work collaboratively across the state. So, you know, if there's something that is a device that somebody wants to trial or learn more about, and it doesn't happen to be at our center, we'll collaborate with the rest of the state, and it can even be shipped to you or brought to a center that's close to you. So take advantage of that. Like we said, all individuals in the community can come to FAST and get those services for free. And through the FAST AT Lending Library, like we said, you can loan systems. So not just AAC, but also assistive technology. So think, you know, kitchen aids, vision aids, writing utensils, one-handed keyboards, all sorts of things that you can try out at the demonstration center. But anybody, any Floridian can come and borrow items through our loan library for 30 days. And so that's a really great way as a client, you know, if you're looking into something and you want to see if it meets your needs, that you could try that out before you try to secure funding. Or even as a clinician or a caregiver, maybe you want to learn more about a system that you want to introduce to your client or your family member. So taking advantage of that loan library can really help you to get hands-on experience. And then along with that, you don't just go in there and you're not just on your own. When you come in there, there's assistive technology professionals of various disciplines that can provide those demonstrations and trainings. Right now, the FAST Center here and all of them across the street are open by appointment, so you definitely need to make an appointment, but we're open 5 days a week. So you can reach FAST at 81844-FL-FAST, that's FAAST. And you can also follow them on all social media at FAST Inc. And in addition, you can follow all the things happening here at the UCF AAC Collaborative. We're at UCF AAC Lab on Instagram and Facebook, and we can connect you with FAST as well, and with all the amazing things that are happening at the lab. Lastly, I wanted to say too that we also do support reuse and recycle of devices. So you might come across a client or somebody that you know that has an older system that they don't need anymore, or some type of assistive technology that could be used by somebody else. And so FAST can help you to recycle or turn that in for refurbishment and reuse. So we're really excited and thrilled that we have the center here and that we're in collaboration with UCF Clinic. I particularly, as a side note, love that because I conduct a lot of AAC assessments and evaluations, and I get to take that support and collaboration of FAST to loan the devices for those assessments and see what meets our clients' needs. So we hope you all take advantage and visit us at FAST.
The first one is going to be for Michael. Early on in your presentation, you showed a Bluetooth gyroscope mouse that was fitted to a kind of a glasses style apparatus. Could you give the name again?
Were you talking about the the glasses? Yes. Sure, that was called Glasshouse. GLASSOUSE. So there are some other types of head mouse type systems. There are some with dots on them that kind of, like again, you wear on a hat or a headband, but Glasshouse is the one that had the capability to plug the switch into it.
Perfect. Our most frequently asked question, Michael did a great job of showing us a range of rather pricey equipment. So Poonam, is someone who does a lot of assessments. I know you just talked about different services FAST provides, but maybe you could talk through how you address funding with patients who don't feel that they have the ability to afford this type of equipment.
Well, thankfully, many insurance providers do provide all or some coverage. So as clinicians, you know, it really is our responsibility to find something that's the most cost effective. If I recommend something that they can't get their hands on, then it's not doing them any good. So advocating for them to contact their insurance companies to find out what the coverage is one of the options. But also there are different organizations that provide grants and funding and charitable funding to assist you as well in getting a system. On the other hand, sometimes we might even look at other like options that can provide the same access to the person and see if that's a more affordable option. And sometimes that in the meantime thing that Michael was saying can contribute to that. So insurance funding, but also grants and other types of scholarships. Another one that comes to mind is, like, for example, people might have the Gardner Scholarship or another scholarship like that that can go towards the funds. Any other thoughts you have on that?
No, I think that was wonderful. I do think the reuse services as well that you mentioned under FAST, a lot of those items are available for free to families who are able to come and pick them up. They would not necessarily require any sort of formal assessment either. Families are just able to go and acquire those themselves. Another question that we had, and I think we've got a couple of panelists who can probably speak to this, but are AAC devices usually suitable for younger clients like children with disabilities as well?
I should ask the students in the room to answer this question. Yes, the answer is unequivocally yes. We know that AAC systems, whether low, mid, or high tech, can support rather than impede language development in very young children. And so, of course, it always requires a thorough assessment to understand the child's skills and abilities, but we advocate for the introduction of AAC at a very young age to support functional communication, reduce frustration, and also to support language learning as the child is moving through developmental stages.
Julie is someone that will really advocate for very young introduction. And certainly, as I was highlighting for you, you saw as the example in terms of the research that we're conducting here at UCF. We're working with many preschoolers, and we are looking at helping them to develop their language skills through the use of AAC. AAC is just a tool to help facilitate that. So then moving on up through the spectrum, of course, we need to support all of the needs, and Michael was talking about some examples. There are lots of social media needs these days, that particularly I have a couple of teenagers myself. So thinking about all of the ways that they communicate and that are so important to them, we need to make sure that we're making all of these connections through our AAC devices and other assistive technologies to make sure we're supporting all of that type of functional use.
We just had a question come in about Stephen Hawking and whether or not he used an AAC system. So very quickly, that would be a yes. He used an augmentative system. He partnered with Intel directly to kind of customize the work that he did. He had a cheek switch for a lot of his life, and most of his major publications were created utilizing an AAC system. Another question for Michael regarding access. You told us about a case study where you had a client who utilized a big toe as part of their selection. I was wondering if you could share with us a bit how you evaluate for different switch sites.
Yeah, I think the OT and PT, if it's in an inpatient setting, is the importance of collaboration with myself and the primary OT and PT. Coming in as an assistive technology specialist, I still look over the initial OT and PT evaluation, but I am definitely doing a full motor assessment as well for to really double check, because people, especially with low level of functioning, may have different ability to initiate or activate at different times of day, different positioning if they were in the bed during the eval versus in the wheelchair. So if you're a specialist with assistive technology, I think that's part of any AAC or assistive tech eval, is just making sure you're fully evaluating the motor control. So going through and really putting joints and muscles in different positions, not always putting things against gravity. And a lot of times you may need to preface it to someone like, I know, you don't have the ability to initiate movement, or you might have not a lot of movement. So a lot of times I'll prep just saying, I just really want to make sure to see where you're at initially, so we can track progress and see if there's any changes that happen. So that's a long-winded answer of that long-winded way of saying that it's important to be thorough, and it's important to, even if you think they have little to no movement, going through each one of those motor areas you never know what could be a key point to be able to access communication or access the environment.
Thank you. We had another question. What should SLPs keep in mind when collaborating with OTs? I'm going to open that up to the panel.
Could you repeat the last part of that question?
Yes, just what are we keeping in mind as SLPs, as speech pathologists, when collaborating with occupational therapists? And I was opening that up to anyone on the panel to answer.
Maybe Michael has some interesting perspectives.
Yes, I was going to say, I feel like you should start as the occupational therapist. What would you like us to keep in mind when we collaborate with you?
I think just being open to reaching out and collaborate. I think the thing that I've learned from working with so many different speech therapists is there's usually a wide range of comfort levels with AAC, and some people have a lot of experience and some people have a little, and just being, I appreciate as an OT or any discipline, just being open to have the conversation of, what are you guys working on? What are your goals? What can I help with? Because I think that's the main thing when we talk about whether it's multidisciplinary approach or interdisciplinary, trying to collaborate to all make sure we're pointed in the same direction for the same goals. So if there's things that I can introduce in my intervention plan my access methods and my leisure and ADL things that can carry over into what you're working on with communication. Just make sure all the disciplines are pointed in the same direction. And I think more and more it's easy to kind of blend the lines nowadays where OT and PT and ST stops. I don't think it needs to be cut and dry. I think there's room for everyone to have their specialty and their autonomy, but I think that communication is important to make sure we're not all in separate lanes, but to make sure that we're at least pointed in the right direction. So just being open to that communication and reaching out, and if you're not sure, just having the conversation or making the referral. A lot of times, even in the outpatient setting, it can be harder to collaborate among disciplines than if everyone's all in the same house. So, trying to develop those relationships and have those conversations. Hey, I have a client that may be useful. Just be open to initiating that conversation.
Thanks, Michael. Another point that you made throughout your presentation, which I thought was really important, related to the intervention plan. You kept referring to that, and that's something that is really critical. We need to identify the right technology, whether that be specifically AAC or other related assistive technologies, but then we also need to make sure that we have the supports and the ongoing intervention in place across our disciplines to ensure that our clients are getting to the functional use piece. So it's not in 100% of cases that somebody's able to pick up that new AAC device and just use it magically perfectly, right? So I really appreciate how you were highlighting that throughout your presentation, and then again in that response to that question. So thanks for bringing that up.
And I am so appreciative of my speech therapy colleagues who are the experts in language and speech production and guiding me in the right direction, because it would not be successful if I just tried to go in and implement a speech generating device or an AAC unit without the collaboration of the whole team, specifically the speech therapist. So it's true. AAC is truly a team multidisciplinary area.
Michael, I'm hoping you can start this one for us. If a person is visually impaired, what kind of AAC device might be beneficial for them?
Yeah, that's a great question. There's different levels of vision impairment or different purposes. So like we talked about with some of the examples, it might be acuity, it might be field cuts, it might be total vision loss or blindness. There's a lot of assistive technology out there that relies on, I would say, just like text to voice options. So there's a lot of different options, but it's so dependent on the client, honestly. So and depending on what their goals are and depending on what their motor functions is. So I think kind of a classic example of why you need a team approach and why it's not just one factor. It's the cognition, it's the motor control, it's the goals, it's what they want to be able to do, what they were used to doing before with technology.
Poonam, anything to add?
Yeah, I would agree. And thinking about, like you said, I think you're pointing towards auditory output. So you might have a system that has switch access and the client is able to hear the auditory feedback of each selection that they could make, and then be able to activate that even if they're not able to visually see what's going on. Or you might come across a lot of clients that have cortical visual impairment, and that's really an issue with processing that visual information. And so they might be on a spectrum of what they're able to see and visually interpret, and that might even change over time. So you may present something with the switch and auditory feedback, but you may also have that visual high contrast visual perspective on their system. So maybe really dark backgrounds with bright red and yellow outlines, because the research shows that is easier to perceive. So we'll use that evidence-based practice to provide that as well. I have a client like that now who is primarily using the NeuroNode actually, and using that auditory output feedback as it scrolls through to hear what the choices are, but we still have that visual representation for the system. We dim the lights and we have that high contrast for their visual display as he's developing his visual skills.
Michael, you gave an example of why the assessment of an SGDE doesn't stop when they receive the device. And you talked about, as an example, the environmental control aspect and working on that with someone after they received the system. So the question is, how much does something like environmental control factor into the initial evaluation when looking at a device for communication?
So that's a good question. I think primarily the assessment and the device choice is primarily around the speech needs of the client and the speech generating needs and how they're going to use it, where, and the mounting piece. I think so many pieces now are just extras. So a lot of the speech generating devices have the capability to connect and network with a lot of different things, whether it's Bluetooth or IR, even power wheelchairs now with assistive drive controls. It's not a consideration when prescribing a power wheelchair, but pretty much all of the new Promobile or Quantum chairs come with Bluetooth connectivity where someone could connect to one device or several devices with that same access method as controlling the power wheelchair. So I think technology is getting to the point where it's a lot of these higher level devices can do that, and then it's problem solving which things they want to do once they get the device. But I don't know that that's always a main differentiator because more and more devices are getting similar capabilities. I do know that the NeuroNode does sync a little bit more with some of those virtual assistants than some of the others, though.
Anything to add? I think that takes us to our time for our Zoom participants today. Michael is going to stay on to speak with our students here at UCF and answer some of their questions directly. We want to thank Brooks Rehabilitation again, as well as the College of Health Professions and Science here at UCF for supporting this activity today. And thank you, Michael, for your time.
Thank you to Carolyn for moderating today. We didn't do a proper introduction of Carolyn Buchanan, who is our regional coordinator at the FAST Center and faculty here at UCF. So thank you so much for your moderation and planning, especially to you and Julie for all that you've done. So thank you so much.
Yeah, thank you, everyone.
You guys, questions for Michael today?
I don't know how to